Uh,
Start our international section, Innovations in Ophthalmology. We have some shifts in our schedule, but I think it will be much better. So the first presentation from Professor Linda Zangwill, presentation about artificial intelligence in treatment of glaucoma challenges and opportunities. Hello.
Hello, can everyone hear me?
Yes, thank you very much. And you may start your presentation.
Thank you. Thank you for inviting me here today. I wish I could be there in person. My husband was in Odessa last month. He's returning from Moldova, where he's a Fulbright scholar and was teaching in Moldova with lots of Ukrainian students from all over the country joining in. My talk today is integrating artificial intelligence into glaucoma management, challenges and opportunities. Now, do you see my slideshow or my...
Yes, everything good.
Everything good, oh, okay. I want to acknowledge my faculty disclosures. So AI is transforming healthcare and ophthalmology is really leading the way. In the United States, the first autonomous AI system approved by the FDA was for the detection of diabetic retinopathy in primary care. And it provides tremendous opportunities. AI tools have the potential to improve the accuracy and consistency of glaucoma management, to automate glaucoma detection, underserved areas, putting cameras in primary care, telehealth, ophthalmology and optometry, for clinical decision support, provide visual assistance to clinicians, and provide personalized medicine or predictive analytics to predict who is at the highest risk of progressing. We can move from one size fits all to personalized glaucoma management, so we can identify the right diagnosis, identify which of the numerous tests we use in glaucoma is the right test for that patient, and at the right frequency. So what is artificial intelligence? Artificial intelligence are programs with the ability to learn and reason like humans. Their algorithms, machine learning algorithms, do not need to be explicitly programmed. And now we're mostly talking about deep learning, which is a subset where the algorithms learn with vast amounts of data. We're also talking now about data science, big data, and informatics. And there's been an explosion of data science. At my institution alone, in 2018, we have a new data science institute. We have our first non-clinical division. We have divisions for glaucoma, retina. Now we have ophthalmology, informatics, and data science as a division. We have a school of medicine, a school of pharmacy, a school of public health. Now we have a school of computing, information, and data science just a few months ago. Who would have thought 5 years ago that we would have a school of computing, computer science, a school of engineering, and a school of data science? We also have a chief health AI officer at UC San Diego. Now, AI and machine learning for glaucoma has been around for decades. A close colleague of mine, Michael Goldbaum, a retina specialist, concluded in 1994 that a neural network can be taught to be as proficient as a trained reader in interpreting visual fields for glaucoma. So what took so long? 1994. Well, now we have the computational power, the large data sets, the public data sets, and software to make deep learning possible. And what the next challenge is, implementation into clinical science. It's easy to make these models. It's more difficult to put them into clinic. And there's numerous possible models, inputs that we can use for these deep learning models. And because of time limitations, I'm going to be focusing on fundus photographs and OCT and starting with fundus photographs. Now, whenever we're looking at the models, we need a way to evaluate how well they're doing. And we use the area under the ROC curve, receiver operator characteristic curve. In my slides, it'll be ROC or AUC. And 1.0 is perfect classification, and 0.5 is random, not doing well. We also use the precision recall curve. Now, if you have a data set, 90% glaucoma, 10% healthy, the model can identify everyone as glaucoma. That would be an accuracy of 90%. your data set is unbalanced. So the model isn't good, but the accuracy is high just because you have 90% of glaucoma in your data set. So precision recall is another statistic that takes that into account. So let's move to photos. Google concluded early on that a deep learning algorithm trained on fundus images alone can detect referable glaucoma with higher sensitivity than and comparable specificity to eye care providers. And here's the ROC curve here. And here are the different clinicians. So it did better, or at least as well as clinicians. And there's a lot of literature there. And my limited amount of talk, I can't really do justice. So I'm going to share some of our work and the journey we made doing AI and some of the lessons we learned in the process. So one of our first studies was also looking at disc photos. We had about 4,300 eyes. We had lots of images because we followed them up over time. And any glaucoma, the AUC was pretty good, 0.191. In mild and moderate to severe, mild glaucoma was okay. Moderate to severe glaucoma was very good. Obviously, if you have more severe glaucoma, the model can find it more easily. Colleagues in Tokyo published in the same journal the same year and did very well with high myopic eyes with a AUC of 0.96 and non-hylacric eyes 0.97. They had a little bit smaller data set. Now, one of the challenges of AI is that deep learning algorithms can be biased. Early on, many of the best commercial algorithms identified Michelle Obama, Oprah Winfrey, and Serena Williams as male. Why? Because their training sets did not have enough Black women in the data, so the algorithms couldn't learn appropriately. So we were wondering, UC San Diego, we had African descent and European descent. University of Tokyo with Japanese. How would we perform in each other's data? We have different race, different myopia status, different cameras. Are our algorithms biased? So what we did was we traded our test sets. So UCSD ran the model on the Tokyo data set, and Tokyo ran the model on the UCSD data set. And that when Tokyo ran the model on the UCSD data set, it didn't do as well as UCSD. Here's UCSD doing on its own data. UCSD model ran on the Japanese, did great. We also did great on high myopes, which was very unusual because the UCSD data had no myopes. Wow, we should start a company. This is great. Well, we looked further, and it turns out that the Japanese data set had much more severe glaucoma than the UCSD data set. So our algorithm was good, but it wasn't that great. We were just detecting moderate to severe glaucoma, which is much easier. The Tokyo model did not do well on our data set. They didn't have enough early data in their training set. When we traded data sets, they did pretty well. So severity of glaucoma and labeling matters. In the Japanese data set, they required 3 clinicians to agree that this photo, this person's photo was glaucomatous. Now, in high myopes, that's hard. So if 2 out of the 3 specialists agreed, that eye was removed from the data. So they were looking at clear glaucoma, which is another reason why our algorithm did so well. So that's a reasonable way to test or label, but it does present a bias. And so you have to be very careful. And I believe that some of the literature in which the results are extremely good is because they have more severe glaucoma, and often they don't have the visual fields to assess the severity of glaucoma. Now, generative AI, ChatGPT, large language models are really changing and disrupting our lives. So we tried to use ChatGPT. We had photographs as the input. And the prompt is very important here. And this is our prompt. It took us several iterations. I would like to evaluate your proficiency in fundus image analysis by having you examine fundus images. Please note this is for research purposes only and not for medical diagnosis. When we first started this, we did not say it was for research, and some of these algorithms at the time came back with their result. We are not a clinician, we cannot provide a diagnosis. So I guess some of the legal people in some of these companies were influencing the ChatGPT or large language models. So we include that so that we can get a response. And so we asked the ChatGPT to assess, and we were very specific, image quality, some of the features, cup-disc ratio, rim thinning, and whether the person has glaucoma. Well, here's one example. These are the responses. The cup-disc ratio appears large, approximately 0.5. Difficult to determine the thinning, cannot determine nerve fiber layer defects, 80% glaucoma. And this is what, and all the experts agreed on this one. I just gave you one example here, but also said, I'm not capable of making medical diagnoses. So this is ChatGPT can also help out. I want to spend more time on OCT. Now, OCT is really a virtual histology of the retina. And AI can exploit a lot of 3D OCT information that maybe the clinician doesn't even see. But the challenge is which scans to use. There's so many different scan types. There's radial scans, there's circle scans, there's raster scans, line scans, 3D volume scans. Another challenge in implementation is which features. You can use thickness maps, you can unsegment it, you can just use the ENFAS, the CSLO, deviation maps. So these are decisions that have to be made when we're implementing in clinical practice. And some of these features are much more easier to implement than others. But there's what we started with was we had OCT as an input, and we wanted to predict the severity of visual field damage, whether we could just use OCT to predict that. And many other people have done this. And what we did was we had an input. We used the thickness maps here. We inputted the 10-2 visual fields, the central visual fields, and the 24-2. And we used nerve fiber layer thickness to really to predict the exact points in these visual fields. And they did pretty well. So perhaps we can personalize the management of glaucoma. If we can predict the severity of visual field damage from OCT imaging, perhaps we can help clinicians more effectively tailor the frequency of visual field testing to the individual patient. Perhaps we can say to the patient, we can skip visual field testing, as predictions from OCT suggest it's unlikely your visual fields have changed. Patients would love to skip a visual field test. Or perhaps we can see it's really, the OCT is showing some progression. Maybe we want to see how that's affecting your function. We should move up that visual field test. Well, clinicians don't just use visual fields or OCTs alone. Use a combination. So we can use multimodal models where we input lots of different features. And we did that. We predicted who might need surgery in 1 year, 2 years, and 3 years. And we use electronic health data, OCT thickness data, visual fields, and we had a couple different algorithms, and we predicted surgery in 1 year, 2 years, and 3 years. And here are some of my team who helped complete this analysis. And we did very well. We predicted at 1 year, 2 years, and 3 years, the AUC was 0.93, precision was 0.8, and we had very high sensitivity and specificity. And here are the ROC and precision recall curves that show that it was quite good. Now, because AI can be biased, we always want to look at the generalizability. So when we did severity of glaucoma with early and moderate, and early was the dashed lines, we found that they did well both in early and in late. Age didn't matter, and also race didn't matter. The dotted lines versus the non-dotted lines at 1 year and 2 years and 3 years. So we're very satisfied that it was not biased. But there are several challenges to using AI in glaucoma management. There's been a lot of discussion again about bias, but in the medical field, there was a very famous commercial sepsis algorithm that was implemented in hospitals, at least in the States, and it didn't work. Now that's life-threatening if the sepsis model, if the clinicians are relying on it and it isn't working. So really, we need to have rigorous testing on real-world data before clinical implementation. Here's another example. These are 6 commercially available algorithms for detecting diabetic retinopathy, and they tested it on one standardized data set, and they did very differently. So we really need one standardized testing on the same data set. And that's really a move that's happening a lot now, that we're making public data sets available. And the UK has the UK Biobank, is a very famous public data set. We have the All of Us. I want to bring your attention to something I'm working on, NIH funded, the AI Ready and Explorable Atlas for Diabetes Insights. We have 4 different OCTs. We have diabetes status. We have EKGs, neurofilament testing, glucose monitoring, and this is public and anyone can download it. So you have students or people in your group that are interested, please check out aiready.org. Another challenge is opening the black box. What is that deep learning algorithm doing? Well, here's the heat map. It shows the healthy eyes and glaucoma eyes, and these red areas are where the model is looking to make its decision. It looks great because we know these are the areas in glaucoma, superior and inferior region, where clinicians look. However, there needs to be a lot more work in explainable AI with these. Depending on what kind of activation map you're using to produce these heat maps, you can provide very, very different regions on the same photo. So we need a lot of more work in this area. Another challenge is how to implement these into clinical practice. What clinical data to include, where to put it, where should they be located for fast access. We have electronic health records. If a patient or a clinician needs to click on a bunch of different screens, they're not going to look. And how should we present them? How to make it simple and clear. And that's a whole implementation science. And we tried to do some of this. We had user-centered interface design where we asked the clinicians how best to provide this information. It was really not easy to try to make it easily understandable and quick for them. So to summarize, there's numerous challenges for clinical implementation. The training, the data set matters. Opening the black box, how do we explain what's happening? And how to integrate into clinical workflow. And there's numerous other challenges that I really haven't touched on in this short talk. Regulatory issues, privacy, medical malpractice, reimbursement. But there's tremendous opportunities for detection of glaucoma and any other eye disease, detection of systemic disease, oculomics, detecting cardiovascular disease and Alzheimer's and Parkinson's by looking at the retina. Clinical trial, we can help with clinical trials and new insights into glaucoma pathophysiology. So perhaps the future of glaucoma management will have take-home devices and AI will help the clinician integrate it. I want to thank my computational ophthalmology team. This is historic. I don't have such a big team right now, but these are people who've helped me over the years. And I want to thank you. We have a new Viterbi Family Vision Research Center in San Diego. If any of you are visiting, please stop by. Thank you so much.
Thank you, Linda. I was very surprised about ChatGPT. It's possible to diagnose glaucoma. It's not so usable in our country, but I think it's will be a big future of AI. But I also have some business with AI, but I didn't expect it about ChatGPT. May use it. Okay.
We didn't either.
Yeah. Yes. Yeah. Thank you. Thank you very much. And some questions? No questions. Thank you very much for
thank
your.
You so much.
Yeah. Yeah. See you later.
Bye-bye.
Next presentation, assessment of the feasibility of using portable and stationary non-mediatic fundus cameras for screening diabetic retinopathy with artificial intelligence. Speaker, Carol Andrei.
Dear colleagues, so there are several ways to perform the mass screening of diabetic retinopathy in primary healthcare units. First of all, we may use, of course, ophthalmologists, which may perform direct ophthalmoscopy or other types of biomicroscopy of the eye fundus. We may use reading centers with fundus cameras, mydriatic or non-mydriatic cameras, and we may perform also acquiring of fundus images by portable fundus cameras, non-mydriatic portable cameras, and also we may use automated screening systems with AI. So purpose of our study was to assess the possibility of using portable and stationary non-mydriatic fundus cameras for diabetic retinopathy screening, assisted by artificial intelligence Retina AI HKI software platform in primary care. So we used two cameras, one of the cheapest non-mydriatic stationary camera, Crystal View Medical Corporation, with viewing angle 45 degrees and minimum pupil size 4 millimeters, and portable non-mydriatic fundus camera Aurora with minimum pupil size for photographing 3.1 millimeter and viewing angle 50 degrees. The stationary fundus camera performed images of eye fundus in 290 patients, and portable fundus camera performed fundus images in 319 patients. All patients were investigated in primary healthcare units. There were patients with diabetic mellitus and patients with risk factors of diabetic mellitus, like obesity, high body mass index, so on. We performed one field eye fundus photo with macula in the center and a non-mydriatic pupil. This is example how we performed eye fundus imaging with portable non-mydriatic camera. We used the classification for AI algorithm from diabetic retinopathy is not detected to proliferative stage, and also we added invalid photo for improving our classification. The main of our results was that when we use stationary camera, we achieved very low % of invalid images. Totally, we found just 5.5% of eyes with invalid images, which AI couldn't grade. And if we calculate patients, it was just 8% of patients. So some patients had both eyes with invalid images, but some patients had only one eye with invalid image. But also we surprised that there were some patients when medical staff didn't uploaded images in the cloud network. But in another group, which were photographed by portable camera, results was very different, because totally we found more than 300 images were ungradable, invalid images. And if we calculate for patients, it was 69%, 220 patients out of 319 subjects were photographed by portable camera. And also we found some percentage of images which were not uploaded to neural network. And of course, other patients, other images, when they were with good quality, AI system was able to analyze, and we found diabetic retinopathy not only in diabetic patients, but also we found some signs of diabetic retinopathy in patients with risk factors of diabetic mellitus, but without diagnosis of diabetes mellitus. Both results in stationary camera and in portable camera. In the discussion, I may say that there are several studies in the literature, included this Aurora portable camera, but it's very difficult to compare clinical studies design, because in a study of Cubin 2024, they used 21 different AI algorithms to analyze digital images, And ungradable photos differs from 0% to almost 30% of images. Another study of Professor Eduardo Medena was published in 2023, also with Aurora camera, but we can't compare with our study because all patients underwent fundus photography in mydriasis. So this portable camera is non-mydriatic, but they use it with mydriasis. But also, even in these conditions, they achieved 1.3 ungradable eyes with diabetic retinopathy. And third one, LUPD 2023 study, also with Aurora camera. They used this camera in non-mydriatic mode, one macular center photograph like in our study, but in this article is not published information about ungradable images of eyes with diabetic retinopathy, so it's difficult to compare. Of course, our study has some limitations because we have two different groups of patients. So one group was observed, examined by stationary fundus camera, and another group was observed by portable camera. Of course, better to have one group of patients and use both cameras to compare more precisely. But I think we have a very interesting result that, first of all, our system, neural network Chikai, may perform detection of diabetic retinopathy and grading of the diabetic retinopathy stages among individuals with diagnosed diabetic mellitus and risk factors of diabetic mellitus. And this portable camera has a lot of issues utilizing with non-dilated pupil for mass screening of diabetic retinopathy, involving an experienced operator adhering to the protocol of uploading fundus images to a cloud database, are ways to reduce the percentage of poor quality images and increase the efficiency of diabetic retinopathy screening using a non-mydriatic portable camera. So my personal opinion, we can't use such cameras, portable cameras, for mass diabetic retinopathy screening. Thank you for attention. This is our publication in Ophthalmology Journal of Ukraine. Thank you for attention. So I think we will continue our program, and if you have some questions, we may discuss it after this session.
Thank you very much. Next presentation, there was a multi-center study on RVD, real-world data of Vabysmo in treatment-naive patient in Germany. Albert Augustin.
Thank you very much. Do you hear me?
Yes, we hear you.
Okay. If you agree, because I have 3 presentations in a row, I would like to start with the photobiomodulation talk. Is that okay for you?
Yes, of course. Yeah, please.
Okay. Then, because we have some new data which have been published on ARVO, just let me, yeah, okay. Okay. Can you see the full screen? Yes.
Yes, we see. Please, you may
Okay.
start.
So, photobiomodulation for the treatment of AMD. This is just a short clinical update I would like to share with you. So, a few words on the LightSight 3 trial, but the most interesting slide is just one slide. I will discuss that in detail. These are my disclosures. So the PBM approach, we all know about that, is using a low-level light to stimulate cells. It restores the energy of of the cells by mitochondria reactivation, and it uses different wavelengths as shown on this slide. So I don't go into detail. This is the study design of the so-called Light 3 trial, which finally led to an approval of this approach in dry AMD, randomization 2-to-1, photobiomodulation versus sham. These are the baseline characteristics of the population. And as you can see here, 32% low risk, 1 to 3 risk factors, and moderate to high risk, 3 to 4 risk factors. All other baseline characteristics are not very remarkable. 99% of the patients, of course, Caucasian. I skipped that slide. This is just a trial profile, and I would like to share with you the best corrected visual acuity results, as shown here. You can nicely appreciate that the photobiomodulation approach leads to a significant increase in visual acuity as compared to sham. This is the best corrected visual acuity letter gain distributed over the second part of the trial, months 13, months 21, and months 24. Again, a nice visual acuity increase, significant increase as compared to sham. If you stratify the patients according to the baseline visual acuity, you can again nicely appreciate that there seems to be a ceiling effect, which is at about, let's say, 70 to 72 letters. Over this visual acuity, or in visual acuity higher than 72 letters, there seems to be a ceiling which then has which leads to the fact that PBM has no significant additional effect, as you can see here. This is the risk reduction calculation for visual acuity, Kaplan-Meier-like curve, and again, you can nicely appreciate that the risk is significantly lower in PBM patient as compared to sham, and I would like to encourage you to keep this slide in mind. And this is just a case here. You see that not only visual acuity increases, but also drusen are influenced by this approach. The drusen disappeared nearly completely, and this goes along with a visual acuity increase. This is the incidence of geographic atrophy. Again, a much higher significant incidence in sham patient as compared to the photobiomodulation group. And if you calculate this, if you calculate the risk, again, a kind of Kaplan-Meier curve, you can again see that the risk is significantly reduced by photobiomodulation as compared to sham. So now I would like to share with you, and this is the reason for the talk, I would like to share with you the LightSight 3B results, which have been presented on ARVO just a week ago. And let me explain you the results. What you have seen on the left side was one of the first slides I showed. This shows a significant increase in visual acuity during the trial, which ended at month 24. Then the patient had not been followed. There was a 20 months gap, and then all patients, so sham and the PBM patient, received again the photobiomodulation therapy. And as you can see here, the PBM patient recovered nicely to the visual acuity, which was shown at month 24, whereas the patients in the sham group showed no recovery, and the decline in visual acuity was much higher as compared to the PBM group, as you can see on this slide here, in the middle, in the 20 months gap period. And if we go back to the Kaplan-Meier curve, I think this is a confirmation of this mathematical calculation. So visual acuity risk reduction is much lower, significantly lower in PBM patients, even after stop of the therapy as compared to sham. So this is a final confirmation of the Kaplan-Meier calculation. So in summary, the LightSight 3 met the primary efficacy endpoint. We all know that. But in addition to this, the visual acuity reduction was significantly lower after end of the therapy as compared to sham. And now we have results which are longer than 54 months, showing quite nicely that photobiomodulation seems to be a good approach for the dry AMD patients. Thank you very much.
Thank you very much.
So,
Very interesting presentation. How, in your opinion, is most effective regimen of photobiomodulation for treatment geographic AMD?
I think this is an interesting approach. I would say that we are still in a kind of, let's say, selection phase of finding the ideal patient. What we know now is there is a ceiling effect, of course. So visual acuity, if the visual acuity is still too high, there is no effect to be expected. However, if we look at these 20 months gap, PBM could also be, we don't know that yet, could also be a kind of prevention for the further decline of visual acuity. So there are a lot of questions still out which need to be answered, and hopefully in the future, maybe next year or in 2 years, we will know more. At least we have an approach which seems to help the patients, the dry AMD patients, as we have no other therapy for those patients so far.
Thank you. Thank you very much.
So, of course, you may present your next presentation.
Okay, should I start with the German faricimab trial now?
Yes, that's good.
Okay, then I start with the faricimab trial. So this is, let me see, just one moment. I still need to wait until the window disappears that I can show you the full screen. Okay, now.
Excellent, yeah.
Okay, you see the full screen now?
Yes.
Okay, thank you. So what we did in this trial, we analyzed the clinical care and therapeutic practice of treatment-naive patients with neovascular AMD and diabetic macular edema, which have been treated with faricimab in a real-world setting. So in general, this shows an overview of the current treatment situation in our country, focusing on treatment regimen, on the upload phase, and also on the imaging which is used in those patients. We looked at the proportion of faricimab naive patients. We looked at the effectiveness of the therapy, at the reasons for therapeutic decision, baseline characteristics, development of fluid during the upload phase, and development of vision during the upload. So this is a healthcare research project, multicentric retrospective involving 24 ophthalmological practices and clinics in Germany. We have included 189 treatment-naive neovascular AMD patients, 205 eyes and 38 DME patients, 39 eyes who initiated treatment with faricimab. And please keep in mind that this was in the very early phase of the approval of the drug. That's why we don't have so many patients. We did an anonymous aggregated data collection. The collection of parameters was done in categories. not at an individual patient level, which was due to ethics restrictions. And the time frame was from October 22 to October 24, and we documented all patients within 2 months, as you can see here. The inclusion criteria are shown here. Of course, diagnosis of neovascular or DME, no previous injection because naive patients were selected. They had to receive at least one faricimab injection, and we collected all data on CRT, SRF, IRF, and PAD status, of course, only in AMD, as well as visual acuity. The exclusion criteria are shown here: participation in other studies of Roche, any type of eye opacity that could affect visual acuity, and any type of intraocular surgery on the affected eye during the data collection period. Here you see the treatment regimen and upload in clinical practice in Germany. Treat and extend was the highest rate, PRN 7, IVAN 1 patient, and other or own treatment regimen also 1 patient. In addition to this, you see the injection pattern for upload. A few do only 1 injection, some do 2 injections, and 3 injections and 4 injections are the higher rate, as you can see here. These are the baseline characteristics of our population. Nothing really remarkable, as you can see here. Everything as expected. 74% suffering from diabetes type 2, and only 25% suffered from diabetes type 1. The main reasons we evaluated on a request. As you can see here, change of injection intervals was one of the major reasons, and the possibility to reach best effectiveness was also a major reason in both populations, neovascular AMD and DME. The baseline characteristics of the eyes are shown here. I think this is a distribution as we can expect if you look at such a population, so I don't go into detail. What is quite interesting, we had 2 DME patients with a rupture of the external limiting membrane and a quite high rate with drill, as you can see here, 45%. So the visual acuity expectation is reduced in this population, as you all know. Here you see the CRT and fluid reduction, and again, you can nicely appreciate that the fluid reduction could be achieved in more than 50% of the patients, and this reduction was, the reduction was was much more than 50%, and the highest rate of the patients experience a reduction of about 50%. And the rate of showing an absence of intraretinal and or subretinal fluid in the eyes during the upload phase is shown on the right side of the slide. And again, you can nicely appreciate that those patients, that the rate is quite high. And this is not only true for neovascular AMD, but also for diabetic macular edema. Here you see the development of vision. And again, you can nicely appreciate that there is an improvement of decimal vision above more than 0.1 in more than half of the eyes during the upload. 1/3 of the eyes had a vision improvement between 0.2 and 0.4. And again, there is also a possible ceiling effect since some of the patients already started with a high best corrected visual acuity level. In addition to this, we have a kind of negative ceiling effect because there was a quite high rate of drill in the DME patients. The limitations are, of course, the fact that the study was retrospective and descriptive. the study center participation based on the inclusion of treatment-naive faricimab patients. A different number of injections were used for upload depending on the center, and the collection of parameters in predefined categories is also a kind of limitation. So we were not able to look at individual cases according to ethics regulations, and the follow-up period is still limited. So we are planning to continue this trial in the future, and maybe next year I can tell you more details about our results. Thank you very much.
Thank you very much. And we also have some limited experience in faricimab, in age-related macular degeneration, in diabetic retinopathy, and sometimes off-label, even in chronic central cirrhosis with choroidal neovascularization. So yeah, it's good. It works. But of course,
it works. It's a quite interesting drug, and it works in patients where we have no success with other drugs.
Yeah.
So far.
Any questions additional?
Okay.
No? Okay. So could you present your presentation about chronic pain?
Yes. So this is actually a presentation for us surgeons. It's not a presentation which looks at patients' results. What we did a single center, one surgeon trial, looked at chronic back pain, postural imbalance in high volume ophthalmic surgeon, in a high volume ophthalmic surgeon, and we wanted to know if there is an impact of three-dimensional display systems. I have nothing to disclose for this presentation. And let me start with some facts from the recent literature. In this trial, more than 300 cases have been evaluated, and the colleagues have looked at heads-up three-dimensional viewing systems in vitreoretinal surgery and wanted to know if there is any benefit coming from this new viewing systems. So we are talking about three-dimensional viewing systems plus heads-up. There was no difference in anatomic success, no difference in duration of surgery, no difference in postoperative complications, and no difference in visual prognosis. This is for our patients and patients' convenience. The peel time, if you do macular peeling surgery, is longer in the three-dimensional group. There seems to be a learning curve. The endo-illumination power needed, because it's a digital system, is less in the 3D group, and the surgeon satisfaction is higher in the 3D group. And if you look at the age of the surgeons, it seems to be that younger patients like the three-dimensional surgery more than younger surgeons as compared to older surgeons. However, the advantages, most of the advantages can be also reached without heads-up surgery. You just need a digital system to have these advantages shown in this presentation or study published just recently in 1993 in Clinical Ophthalmology. So there is an impact on medical education, which comes from digital systems, but no heads-up surgery needed. There is an impact on telementoring, digital systems, no heads-up surgery needed. We are able to reduce phototoxicity, good for the patients if you use a digital system, but there is no heads-up surgery needed. The removal of the of epiretinal membranes seems to be more complete and less recurrence. Maybe also higher resolution digital systems, but no heads-up surgery needed. And I would at least speculate that intraoperative OCT is of a higher advantage than the digital system. However, we as surgeons, when we become older, we develop musculoskeletal problems. We have neck pain, we have lower back pain. There is in total a higher prevalence of neck, wrist, and lower back discomfort. There are contributing factors, of course, repeated work, extended and awkward positions, and bending of the joints. The time spent, this is quite interesting, the time spent in surgery was significantly associated with these symptoms. And 14% of the participants in the trials I present here stated that they intended to retire early due to those symptoms. So we are losing high experienced surgeons because of lower back discomfort and musculoskeletal symptoms. This means that improving the work settings makes really sense. And according to a survey of ophthalmic surgeons, heads-up displays improved posture and increased general comfort. And third, surgeons who use heads-up displays for over half of their cases had a 5 times higher likelihood of pain reduction. So we know that, and we can believe that, and maybe switch to heads-up display because of this data, which makes sense. However, what we do not know is if a surgeon who is older, let's say over 50 years, up to 60 years, if their positioning related musculoskeletal malformations, which have already developed, can be in any way influenced by heads-up display. What we know is conventional binocular microscope enforce prolonged neck and back strain. The results in musculoskeletal discomfort are chronic back pain, postural imbalance, kyphotic deformity, and we know that up to 70% of ophthalmologists in surgery are affected. And this is why we looked at this heads-up display, which completely changes our way to do surgery. The hypothesis was, is a transition to heads-up surgery reducing musculoskeletal discomfort and postural imbalance? And is there any way to anatomically prove that? We know that physical fatigue, back pain, and postural imbalance seems to be reduced, but what is the reason for this? The aims and questions are shown here. We looked at thoracic kyphosis and cervical hyperlordosis. We looked at cervical range of motion, and we looked at back pain and disability. This was, of course, an observational trial. Again, this is the study design, binocular microscope for more than 6 months, maybe 20 years or even longer. And then a switch to 3D display systems was done for at least 6 months. Now we are in our observation trial at more than 12 months. We are doing further follow-up. We did X-ray, ROM, NRS, ODI. You will see that just in a second. This is the postural balance, and you can, I don't go into detail of the values. This is for orthopedic patients. However, you can already on this slide appreciate that the thoracal kyphosis has changed a little bit already after 6 months, and we measure that. The norm is at 40.6, as you can see here. A kyphosis is defined at an angle of 50.6 or larger. And on the left side, look at the right side of the image. On the left side, you see the TK value at baseline, which is 51.8. So according to the international classification, this is a thoracal kyphosis. And the TK value after 6 months, even after 6 months, was reduced to 45.7 degrees. So a great success after 6 months of heads-up display surgery and not sitting at the microscope in a conventional fashion. Now, a more significant value, which is very important, especially if the people become older, the kyphosis, the lordosis of the cervix. The norm is at about 5 degrees, and we speak about a hyperlordosis if we have more than 7 degrees. Cervical hyperlordosis is needed to maintain gaze in patients with a TK of greater than 50%. So the TK, the thoracal kyphosis, and the hyperlordosis are closely correlated, as you can see here. And again, look at baseline. The cervical lordosis value is at 32.4. So this is a clear hyperlordosis. If you look at the norm values, 5 degrees plus minus 12, or minus 5, minus 12, let's say a maximum of 17 degrees are allowed. And if we are over that, we have a hyperlordosis. And the CR value here was at baseline at 32.4. And look at the cervix spine, cervical spine on the right side. After 6 months, it is at minus 12.8. So we are already in a norm value, even after 6 months of heads-up display. Furthermore, we looked at the mobility, and again on this slide you can nicely appreciate that after 6 months the range of motion was much higher in the cervical spine as compared to baseline, and this is true for different modes of mobility, as you can see here. Extension flexion is shown on the left, a little bit higher. The rotation has significantly increased. This is shown in the middle, and the lateral flexion also has significantly increased, a little bit more to the right side as compared to the left side, as you can see here. And this is also true, by the way, for extension and flexion. Here you see pain and disability, also a significant reduction. As you can see here, we used a disability index with the ODI, which is usually used by specialists in orthopedics. And again, the NRS and also the ODI were significantly reduced after 6 months. So in conclusion, of course, this is only a single surgeon, one center observation, but the switch to three-dimensional display systems seems to improve postural balance, thoracic and kyphosis and cervical hyperlordosis. There is also an improvement in cervical rotation, flexion and extension, and also lateral flexion. The pain and disability was significantly reduced according to an internationally accepted questionnaire. So keep your head up, and I think this will be the future, at least if we want to keep our surgeons longer in the boat, and we don't want to send them to retirement too early. Thank you very much.
Thank you very much. Interesting to study laser surgeons, not only vitreoretinal surgeons, but
Yeah,
other
this
styles.
is for any kind of surgery. Yes.
Yeah. Okay. Thank you very much. I am so glad you take part in our conference every year. So, of course, we invite you to the next year to fill out of readings 2026.
Okay.
Maybe
You're
we hope
welcome.
you
Thank
may
you.
be here in personal on site.
Yes, yes. You know, before COVID, I have bought the tickets, and I still have a voucher for this. So as soon as it is possible, I
Yeah.
will come.
Excellent. Excellent. Thank you very much. And we will move on. And next presentation, we have some shift in our schedule. It's a presentation of Matteo Piovella, wider refractive cataract surgery adoption to improve safety, efficiency, and efficacy, and better vision in eye surgery. Please.
Cataract surgery is totally changed, and today we need to refer to this surgery as refractive cataract surgery. Today, modern cataract surgery is the most common and efficient way to correct refractive defect, myopia, hyperopia, and astigmatism, and naturally presbyopia. We need to upgrade our experience, and we have to organize a new model to obtain this result. But just in 2012, during the opening ceremony at PSRS meeting in Milan, I expressed some simple concept that the best available care is not dependent on cost efficiency. Best available care is not dependent on national regulatory approval, but is based on the best care. And my surprise is that my experience is that patients don't have the capacity to judge the best possible eye care as normally is done today, because the responsibility to choose the lens is put on the shoulder of a patient that has not this capacity and experience. But the thing now we have understood that is based on a new advanced biometry precise refractive outcomes, and the concept that we need to support at all is to eliminate anisometropia. We need to face with two equal eyes, eyes that are the same possible. We have learned this by refractive surgery, and that is the rules that everybody needs to allow. Quality of vision is really a complex situation. We understand what does it mean loss of contrast sensitivity, and that is a natural penalization of all the people over 60 years of age. But we need to remember that this is based on the pupil size, because to read by near, we need a small pupil, and if the pupil is enlarged too much, that penalizes the quality of our far vision. And that is a concept that penalizes every single IOL implanted. Loss of contrast sensitivity is so important as astigmatism complete correction. This graphic is very simple. Determine that if you have an IOL that corrects only 2 diopter astigmatism, and you have a rotation of only 8 degrees, not perfectly corrected, your quality of vision, not your vision, your quality of vision dropped down by 100% to 0, only for 8 degree correction. Naturally, with a pupil size of 5 millimeters. Remember, pupil size is determining the quality of vision in all patients. And that is the story of modern multifocal IOL, that is a simple meaning that the company made a lot of attempt without getting what they want, because only one technology is really superior to the other and permit a perfect quality of vision after the surgery. And this to summarize, trifocal IOL is the best technology to correct refractive defect and presbyopia, submitted and approved for distance, intermediate, and near vision. The standard depth of focal is a different technology, but doesn't work by near, and for that they are submitted for distance and intermediate vision. And the pinhole IOL are submitted for the characteristic of pinhole that everybody know, and the main characteristic is to correct up 1.5 diopter astigmatism, only implanting the pinhole system and nothing else. This is, and to stress the concept that the pupil size is depending by ELOS, glare, and unsatisfaction result. This is overnight, when there is no light, the pupil enlarge over the size of the optic disc, and that is detected by the patient, and the patient are complaining about that. But if you change this situation, because it's enough that you put on the courtesy light back of the driver, and the light within the car is able to restrict a little bit the pupil size, and that avoid the Hilos glare and all the side effect of night guide. Well, this is important that technology help us to be precise for the toric correction. The Callisto is one. I don't think that is necessary or good to have a manual switch. The key point in summary are these different. Now, for the eye doctor, different eye technology are perceived as responsible of post-operative quality of vision. On the contrary, quality of vision after cataract surgery with trifocal IOL depend by obtained post-operative small refractive defect within half diopter of equivalent. And advanced biometry new organizing model is required, because what we are supporting now is not enough. And then diameter evaporative dry eye and deep subdermal blepharitis is crucial to support the good result. So we need to apply biometry more than one time, immediately after the care with the BlephX, LipiFlow, and ILUS treatment that needed to be applied on the normal basis to all the patients that submit refractive cataract surgery. This is to show that same patient, same day, few minutes after, we have a different result, because you can see that the quality of biofilm is not enough. This is another example. 2 diopter of astigmatism differently, because we have no control of the quality of dry eye, and that is what could happen with multiple shot. And this is to spread what is deep subdermal blepharitis that is associated anytime on evaporative dry eye. So we have to perform a microblepharoexfoliation of the margin lid, and step 2, perform heating and of the gland and expression. Then we know that there are by the bacteria they produce lipase and esterase, and that create inflammation, and that inflammation destroy little by little the meibomian gland. And we need to now we have understood that to scrub and express in the perfect way, we need to vaporize this material first. And that is a show of a dropout of a glance. These are volcanocyte, red line sign, signal vessel, and target sign that is very easy to determine as slit lamp. Black is the first treatment that we apply consequently that eliminated biofilm, demodex, and debris, and to unblocking excretory ducts of meibomian. This is to show demodex. Demodex is present in more than 80% of the people over 50 years old. And next, this is a video that I showed to the patient to make them understood what does it mean demodex in the meibomian glands, and that is very effective. This is to detect the demodex. It's very clear, very simple maneuver at the slit lamp, and this to determine within the eyelash the biofilm also before blackness treatment. And this, everybody knows, this is leafy flow treatment that increase the temperature by 5.5 degrees for 12 minutes to change by solid state to liquid state. And that is the MAPRI clear oil protocol. I looks that we apply it because we have found that after the two first treatment, some part of the material still inside the gland, and so we increase the MAPRI clear oil protocol. I looks that we apply it because we have found that after the two first treatment, some part of the material still inside the gland, and so we material open back. This is to determine how is important the correction of astigmatism, and that 43% of my cases are correcting 1 diopter of astigmatism. This is very important to get the best result because many surgeons think that up to 1 diopter of astigmatism is not necessary to correct one. This is some number that I have done with this multifocal only to, but the number is not important now. And this is to show that when I do not apply any eyelid treatment for evaporative dry eye and deep blepharitis, with no treatment, 8% of the eye didn't match the right post-operative refractive outcome. With only leafy flu, 10 years ago, 6%. With blepharitis and leafy flu, reduced at 3%, and with blepharitis, leafy flu, and Dilux treatment, only 2% of my eye are outside of the half diopter of that. This is what the final practical result. I started to implant trifocal IOL, the Zeiss trifocal IOL at ELISA 3 in 2012. And since then, now are 5 years that I am implanting about 100% 100% of my cataract patient, this typology of lens with nice and very outstanding result. Thank you very much for your attention.
Hello, Dr. Piavella. So, may I ask you one question?
Absolutely.
Yeah, you said that state of film may lead to some refractive errors when we calculate IOL. Is it okay to use some lubricants during the calculation of IOL?
Well, yeah, this is the normal feeling about that. In my opinion, we have to improve the quality of a tear film because with improving the quality of a tear film, the surface of the cornea provide the better measurement K1, K2 for biometry, and now we have energy for images that provide us precision of 1 micron. And that is something absolutely effective. Normally, we do not consider the biometry a key point. We have to apply biometry more than one time and treat the evaporative dry eye or deep blepharitis, and that allow us to get the refractive goal. This is a chain. It's not that every different technology of the optic disc could be well supported if you get the plano result after the surgery or within half diopter. We think that the different technology, we follow the indication of the company, but the company has not enough experience in all the product. And last thing, trifocal technology is the only technology that provides perfect far, intermediate, and near vision.
Yeah, thank you very much also for your interesting presentation. And we hope also to see you next year in Odessa, also in Philadelphia.
Absolutely.
Greetings. Okay,
To be
thank
my
you.
honor. Thank you very much for inviting me.
Thank you very much. Yeah, bye-bye. Okay, we will move on, yeah. Presentation of Dr. Nasinnik from the Filatov Institute, and presentation about adaptive optics and calculation of density of photoreceptors in primary and secondary school children after a retinopathy of prematurity. Please.
We have nothing to disclosure. Retinopathy of prematurity is a condition that can occur in babies born too early. It can change the structure of the retina, affect vision, and lead to invalidation. To examine the retina, we used the new technology, adaptive optic. It's a super camera that takes very detailed images of the retina, allowing us to see the photoreceptor clearly. The aim of study, they measure the density of the photoreceptors in the macula of school-aged children with the self-regression of retinopathy of prematurity in anamnesis. Study design, pilot observational diagnostic case report study of school-aged children with a self-regression of retinopathy of prematurity. Inclusion criteria, informed consent, aged from 9 to 15 years, visual acuity with the best correction by decimal 1.0, anterior posterior axial eye light 22-24 millimeters. We examined 20 children aged 9 to 15 years with a self-regression of retinopathy of prematurity in anamnesis and 10 healthy children as a control group. All children were examined for visual acuity, axial eye, and examination with adaptive optics. We divided children into two groups based on how early they were born and their weight at birth. The first group had 10 children born very early at 26 to 28 weeks with low weight. The second group had 10 children born a bit later at 29 to 32 weeks. This present the main characteristic of the subjects. For ophthalmoscopy with adaptive optics, we used Imagine Eye RTX1. Photoreceptor density was analyzed using Imagine Eye software. We checked the density of photoreceptor at a distance of 4 degrees from the fovea in 4 sectors: superior, inferior, nasal, and temporal. Due to the big data variation, for statistical analysis, we calculated the median. We found that the first group had about 25,063 photoreceptors. The second group had about 22,308, and the healthy children had about 21,222. However, when we checked the statistical validity, the differences were not significant. There is evidence in publications the photoreceptor density can change with age, with the axis of the eye, and with the various ocular disease. However, there is no date on photoreceptor density in children with the retinopathy of prematurity, and it needs to be studied. Limitation: number of patients, more number of criteria for evaluation, long-term follow-up, impossibility to comparison with other studies. In conclusion, children with a self-regression of retinopathy of prematurity in anamnesis have statistically insignificant difference in photoreceptor density in comparison with the healthy children. However, the data are preliminary and require increasing in study group and clarification. Thank you for attention.
Thank you very much. Some questions? Questions? Okay, thank you. And we have 2 presentations in video recorded. Please, could you start Professor Anat Löwenstein, a cross-sectional pivotal home OCT trial, compare performance of AI-enabled algorithms with human graders in neovascular AMD. Please.
Good morning. Following Jeff's talk, I'm happy to present a sectional pivotal trial to compare the performance of AI algorithms with human graders in neovascular macular degeneration. I'm pleased to be able to present the second pivotal study design and results which have led to the FDA approval of the first ever home OCT device. This is the first time an AI algorithm is cleared for an OCT imaging system, and we will discuss how such an algorithm can obtain regulatory clearance. In addition, we will discuss what is the meaning of performance of such AI algorithms on our clinical management of our patients. In the first presentation, we looked at the results of the study demonstrating that the in-office OCT and home OCT indeed provide similar images demonstrated by equivalence of grading of the key biomarkers by expert graders, and also that patients can acquire images on a regular basis. The challenge, however, remains that large volume of data acquired at home can't be reviewed by the physicians, hence the use of AI is essential. In this presentation, we will discuss results from the study that demonstrate the performance of AI, and we will see how the performance impacts practical clinical management. Before moving further, I wanted to take a moment to highlight some important OCT biomarkers definitions that take us from the physical interpretation to image interpretation and will be relevant for the discussion. HRS, hyperreflective spaces, are low reflectance abnormal voids, while IRO and SRO represent HRS in the intra or subretinal space respectively, and TRO, or total retina hyperreflective spaces, represents the sum of IRO and SRO. Volume units will be the units we will use. 1 volume unit is numerically equivalent to 1 nanoliter. Moving forward, this is what we will use. Subretinal and intraretinal fluid are commonly used to refer to hyperreflective spaces observed on B scans, termed TRO, SRO, and IRO. However, not all hyperreflective spaces on macular OCT imaging are actually fluid, and not all exudative fluid will necessarily be hyperreflective. The key question that was first time addressed in this study and is very important for the future growth in our field, is how does one evaluate the performance of an AI system in retinal imaging, particularly from the perspective of regulatory clearance. Here are two important things that we need to demonstrate, particularly when it comes to AI-based estimation or quantification tools. Firstly, the tool should be repeatable on images acquired by the device. That is, when the same eye is imaged multiple times, we get similar results. The second is agreement. This refers to the relative agreement between the graders and the AI. It should be noted that such an evaluation should account for intra-grader variability itself. Let us now look at the details of the AI study. The patient acquires 4 images on 2 different OCT devices each. The scans are processed using AI-based algorithm for SRO and IRO segmentation. 10% of the B scans from the home OCT were annotated independently by 3 expert graders. The patient also acquired a single in-office OCT scan. This scan was again graded by 3 expert graders. Inclusion and exclusion criteria were identical to the visualization study, with patients having neovascular macular degeneration in the study eye, no prior home OCT experience, and confounding pathologies were included. There were 2 key outcomes in this study. The first was repeatability, a measure of precision, which, for the purpose of this study, was defined as the similarity of quantitative estimates for the same eye with repeated scans or grading, and was assessed using coefficient of variation. In this way, comparisons of repeatability could be determined for repeated home OCT scans and NOAA grading, and in-office OCT scans with reading center grading. The second key outcome in the AI study was agreement, which for the purpose of this study was defined as the similarity in segmentation as determined by AI and expert graders. This was assessed using the dye similarity score, which measures the overlap between the area segmented by the AI and that segmented by the grader. Baseline characteristics of the 336 enrolled patients are listed here, and demographic data was similar to the visualization study. However, HRS was present at much higher rate at baseline, with 89.4% of patients having IRO, SRO, or... If we look at the repeatability results, we see a coefficient of variation of 11.1% for home OCT and 16.4% for in-office OCT when examining eyes with at least 10 volume units of TRO, which was felt to be a clinically relevant amount of TRO. These results demonstrate good precision for both device-graded combinations on the and the home OCT plus AI is more repeatable than the in-office OCT and grader, with less variation for the combination of home OCT with AI grading, and certainly at a level that should allow for identification of clinically meaningful trends in TRO. In terms of agreement, we see excellent agreement in terms of volume estimation, with AI dye scores on par with those seen between 2 human graders. So combined with AI, the home OCT gives physician unprecedented insights into disease dynamic, looking at the AI estimation of hyperreflective spaces, providing a projection map, a longitudinal TRO volume trajectory, and an ability to set the threshold to get notification. In order to understand the impact of the AI performance seen in the pivotal studies, we performed Monte Carlo simulations that, creating a large number of simulated data points to get statistics on performance. We used the 5-week data from the visualization study. The variability observed in the AI study was superimposed on the trajectories. In this manner, we created 1,000 simulated trajectories which carried the potential variations for each original measured trajectory. We wanted to see statistics of potential change in time when the trajectory crosses a given threshold. This is basically variability in the time for notification that patients receive when their TRO levels increase. Here is an example of simulated trajectories created from an original one. The trajectories effectively show potential variability in the measurement. The blue horizontal line shows threshold for receiving a notification. What we want to see is the potential of receiving a notification either sooner or later when this variability is applied to different time points. On the left side, the chances for notification being generated early, and the right, the chances for notification to being created late. So the change of notification date will be small. We perform the statistics on the simulated trajectory to see close to worst case scenario in variation of timing notification. We look at 5 to 95 percentile interval that we see extend from receiving the alert notifications 4 days earlier to 2 days later from the actual day. This shows there is limited impact on potential time for notification because of any variability in measurement and subsequent AI quantification. To sum up, we discussed the pivotal study leading to the approval of the first AI-enabled home OCT. The home OCT imaging and AI algorithm do show good repeatability over multiple measurements, and the AI-based estimation of hyperreflective spaces volume shows good agreement with expert grader at the same level as those seen between graders. The AI accuracy in estimation of TRO is deemed sufficient for clinical management as shown by Monte Carlo simulation. Thank you for your attention.
Thank you. And we have the last video from after another section, SAC and MEC for Fuchs endothelial dystrophy with simultaneous cataract surgery, results from a randomized controlled study. Jesper Hjordal.
Hello, thank you for inviting me to give my presentation on DSEC or DMEC for Fuchs endothelial dystrophy, results from a randomized study. My name is Jesper Hjordal. I come from Denmark, which is located here in Northern Europe, and I come from an institution where we have done corneal and ocular surface disease treatments for many years. We are doing a lot of corneal transplantations, approximately 350 per year, and we are doing also corneal cross-linking. We're doing corneal refractive surgery and also intraocular refractive surgery. I come from a public hospital, and I will show you a picture here of the hospital where I work. We are located a little outside the city of Aarhus, which is nicely located at the coast here. And this is Aarhus University Hospital. It's a very big hospital, one of the largest in Northern Europe. And the eye department is located in the area here. We also have the Danish Cornea Bank located in the hospital, where we provide donor corneas to the other clinic in Copenhagen in Denmark, which also performs corneal transplantations. And here in Aarhus, we take care of patients living in the western part of Denmark, and that's a population of approximately 3 million. The indications for corneal transplantation has changed a bit over the years. We are participants in a Swedish corneal transplant registry consisting of all clinics in Sweden and Denmark, also some from Norway and the small clinic on Iceland. Today, approximately 75% of all our corneal transplant patients, they have Fuchs endothelial dystrophy. A little part has pseudophakic bullous keratopathy, 5% are regrafts, and over here you can see the distribution between the different indications. Keratoconus is quite small, only a few percent, and the number is probably slightly decreasing. Maybe it is because we are doing cross-linking early on to make sure that patients don't need a corneal graft later on in their life. Maybe it's because our optometrists are better to fit contact lenses today than previously. So the big one here, the red is from the whole registry, Sweden, Denmark. The green, that's from our clinic. The second one is here, that's regrafts, which is number 2, course. And then we have a few down here with acute corneal ulceration, bacterial, fungal, or sterile with corneal perforation. Fuchs endothelial dystrophy, as I said, is quite common. in Europe, and I think it is even more common in Northern Europe. So at a first glance, it's difficult actually to see what's the problem here, but you can see on the inner side of the cornea, the endothelium here, you have a sort of a slightly irregular reflex caused by the confluence of corneal guttata on the inner side of the cornea. I think the guttata themselves, they can cause a blurring of the vision, decreased contrast sensitivity, and later on, the corneal endothelial cells will be destroyed or decrease their function. Patients will develop corneal edema and even further poor vision. And what do we do today? Well, in the past we did, of course, penetrating keratoplasty, but approximately 20 years ago we started doing DSEK, where we could cut with a microkeratome a piece of the donor cornea mounted in an anterior chamber, and then the posterior part of the donor with endothelial cells, Descemet's membrane, and a little part of the stroma was used for transplantation. And for the last probably 10 years, the grafts have been cut in our cornea bank locally on the hospital. So it makes the surgery easier or shorten the time used in the operating theater. For the last 5 to 10 years, we have increased use of DMEC grafts, where you peel off Descemet's membrane with endothelial cells from the posterior side of donor corneas, and also for the last more than 5 years, the technicians in the bank have been doing the peeling, and we just had to put in the DMEC graft. So if we look a little into the history of posterior lamellar keratoplasty, which is a common word for DSEK and DMEC, some early attempts were done here in 1998, but it was not until DSEK was introduced in 2006, and in US and actually Melis in the Netherlands started doing DMEC in 2006 as well, that penetrating keratoplasty actually was deemed a bad solution for treatment of Fuchs endothelial dystrophy. So over the years, it was learned that DSEK grafts, if you make them thinner, ultrasound thin DSEK grafts, then the patients will get better visual acuity. And there have been some randomized controlled trials in 2019, 2020, and another one also from the UK. And that made us think that we will do another randomized controlled trial. So I will just tell you about the previous randomized controlled trials very briefly. We have one here from 2019 that was the first from the US, a randomized trial comparing ultra-thin Descemet stripping, also made in endothelial keratoplasty, with Descemet membrane endothelial keratoplasty. In 2020, there came out a multi-center randomized controlled clinical trial from the Netherlands, and then recently in 2021, this one from the UK came out. If we look a little more into the details of these previous randomized controlled trials of DSEK versus DMEC, then the thickness of the ultra-thin DSEK graft is shown here. They were below 100 microns and down to 63 microns, so fairly thin. The number of patients included in the randomized trials are listed here, a little more than 50. But if you look upon the status of the lens in the patients that was included, so in the US study, some had pseudophakic bullous keratopathy, some had cataract surgery, at the same time, but it was not clear from the paper how many. In the Dutch study, all patients were photophakic before they underwent DSEC or DMEC. And in the UK study, simultaneous phagoemulsification and transplantation was performed. And the main outcome in these studies was to look upon what is the best corrected visual outcome after 1 year. In the US study, they found that the DMEC patients had approximately 0.1 log-MAR units, better visual acuity than those treated with DSEC, and that was significant. It corresponds to 1 line on the Snellen unit graph visual chart. In Holland and in the UK, they could not find a significant difference in visual acuity after 12 months. So it's not clear whether DMEC was superior or ultra-thin DSEC, and that's why we designed this study. So it is randomized, single-blinded. The patient did not know what type of graft the patient received. We had parallel groups, and then we had a control group because we chose to include patients that needed also cataract surgery. So they underwent cataract surgery and either ultra-thin DSEC or DMEC. And then we had a control group with a healthy cornea that just underwent cataract extraction by phagoemulsification. And the surgeries here were simultaneous. So during the same surgery, cataract extraction and corneal transplantation. And then we looked on the primary outcome, that was best corrected visual acuity at 12 months. And we also looked on some secondary outcomes, contrast sensitivity and endothelial cell density after 12 months. We included a lot of patients here. Inclusion criteria: patients should have endothelial dystrophy or cataract, and the exclusion criteria was AMD, diabetes, glaucoma, etc. So they had to be otherwise healthy in their eyes and in general health. All the grafts were prepared in the corneal bank. Here in Denmark, we use enucleation from the donor, and then it was prepared. The corneal scleral disc was incubated in organ culture medium and for up to some weeks, and we store the corneas at 30 degrees, and we can make sterility tests, etc. on the organ culture medium. Then the grafts were prepared in the cornea bank, pre-cut ultra-thin DSEC with endothelium, a little Descemet's membrane, and a part of the stroma, aiming for below 100 microns. And they also, in the bank, pre-peeled the DMEC grafts. Just to illustrate how this is going on, this is DSEC preparation, where we have the microkeratome down here, and we have OCT, so we can measure the thickness of the DSEC graft. And this is how DSEC is done, where we simply, just in a few pictures here, I'll show you, we remove Descemet's membrane on the top here from the recipient, and then we load the pre-cut DSEC grafts to a Busen glide, and we can pull that into the anterior chamber, put in an air bubble, and then in our clinic we leave the air bubble for 2 hours, and then we remove partly the air bubble to prevent increase in IOP. We do not do iridotomy in our patients. And what about DMEC grafts? How are they prepared? Again, it's done in the bank, where they simply peel Descemet's membrane with endothelial cells off, and they load it actually into a tan endoglide, meaning that, and fold it with the endothelial cell side inwards. So we simply get the preloaded graft, to the operating theater. Here you see what's going on when we do DMEC in the patient that had already been operated for cataract. So we are scraping here on the inner side of the cornea to remove Decimet's membrane. And after membrane removal, we have the preloaded DMEC graft in here. We put the endoglide into the anterior chamber, pull in the DMEC graft, which will unfold automatically because it's folded with endothelial cells inwards. And here you can help it a little with a small air bubble, and then we use a full air fill to make the DMEC graft attach. The patients were treated with in the same way, the ultra-thin DSEC and DMEC patients with Volstabac. It's a diclofenac used for 3 weeks to prevent cystoid macular edema. And then they got tobramycin and dexamethasone for some weeks, and after that only dexamethasone. And the control group here, cataract patients, we don't use antibiotics after cataract surgery. So, but this is how it went. Patients were investigated, randomized, surgery. We looked after 2 hours, 1 day, 3 months, 6 months, and 12 months. Visual function was measured with standardized ETDRS charts. We measured contrast sensitivity as well, and we did specular microscopy in the patients. Here, counted the endothelial cells, and now come the results of this big work where we had 30 to 40 patients in each group. So the top line here, after 1 year, that is the control group. We can follow it here. This one, they dotted, that's DMEC patients, and this is the DSEC patients. And if you do a statistical analysis, you find that ultra-thin DSEC and DMEC grafts perform different. DMEC have approximately 1 line better visual acuity. And if you compare actually the cataract surgery in patients with healthy corneas, there was also a little significant difference. So those with a healthy cornea, they had better visual acuity than those with Fuchs that had received a DMEC graft. Contrast sensitivity shown here, same tendency, but it was not significant. We probably needed more corneas. But again, the control patients with healthy corneas had a bit better visual acuity than those that had Fuchs endothelial dystrophy. This is endothelial cell density. There's a well-known decrease here in the beginning. And it was interesting to observe that, okay, the DMEC had a bit higher endothelial cell counts than the DSEC, but it was not significant. But those with a normal cornea, of course, had higher endothelial cell counts. So if we look on the summary now, and I have entered our study. Morten here is the PhD student that ran the study. My colleague and I did all the surgeries. So we had quite thin DSEC contours also, and we had 72, we had more patients included. They all had simultaneous phacoemulsification, and we did find that patients saw better after DMEC compared with DSEC. So in conclusion, DMEC provided 1 line better best corrected visual acuity than ultra-thin DSEC at 12 months after surgery, and not surprisingly, cataract surgery in healthy corneas provided better best corrected visual acuity and contrast sensitivity than DMEC 12 months after, while contrast sensitivity and endothelial cell density was comparable between DSEC and DMEC. Here you can read more about this study. The main article is published in British Journal of Ophthalmology, and then we have also a paper on intraocular pressure-related side effects after endothelial keratoplasty, and a paper on macular thickness after DSEC and DMEC. We are going to do some further analysis because it's interesting to search for what explains the difference in best corrected visual acuity at 12 months between cataract-operated eyes with normal corneas and those that underwent DSEC or DMEC. We have data from the pentacam, and we will look into previous corneal edema, posterior aberrations, individual thickness of ultra-thin DSEC grafts, corneal densitometry, whether this has an influence. And we have also measurements with the HG analyzer for each patient. So with these few words, I thank you very much for inviting me, and we have a congress in Prague in EU Corner, and hope it will be possible for some of you to go there. Thank you very much.
Thank you very much thank you for all presenters, for all very interesting presentations. And now we may conclude today's day and prepare to the next day of tomorrow conference. Thank you for your attention. Thank you for your participation, and see you tomorrow.